And I love these classic artworks because it doesn't look like you're practicing medicine. It looks like you're torturing people. This kind of fits in with the Halloween theme. Maybe we should move it up a little bit. But it's the loss of perception and this loss of feeling. And if you're lucky, it accompanies a loss of consciousness. And so really, you're using these drugs to essentially get kind of a little bit ahead of the brain and get the patient ready for surgery. So there's 4 stages of anesthesia. Stage 1 is basically just analgesia. So essentially what you're doing is you're controlling pain. So the patient has a decreased awareness of pain. So they can sometimes feel a procedure occurring, but it doesn't hurt. Okay, and so consciousness is typically impaired, but it's not lost. So the patients are slightly aware that something's happening, but they don't feel a lot of the pain. The second stage is this notion that we introduced kind of early on in the introductory pharmacology course, component of the CNS course, is this notion of disinhibition release, which is really delirium. Okay, and so the patient appears to be delirious and excited, and so this is where you see those viral videos of somebody going under anesthesia. And of course, when we talk about classic anesthesia, we see people going to sleep, but there's a little bit of a phase early on, which is this disinhibition release, where they get agitated, anxious, they ramble, they say inappropriate and funny things, and those are the things that are typically posted, hopefully with the patient's consent, on those YouTube and Facebook videos. But it's the concept, again, of disinhibition release is this paradoxical excitation as you are inhibiting the brain. And the reason is, remember we talked about the amount of inhibitory neurons versus the amount of excitatory neurons? There's more inhibitory neurons. And so when these drugs start, these depressant type drugs start going through the brain, the first effect they have is on the inhibitory neurons. So if you inhibit the inhibitor, what's left are the excitatory neurons. And so the first bout, the patient actually gets really excited. And the example that we talked about specifically with disinhibition release was alcohol, which many of you may have varying degrees of experience with. But we all know that the first drink usually loosens you up and makes you more chatty. The second drink, maybe a little bit less so. Third, fourth, fifth, sixth drink, pretty much you're going downhill, and by the 7th drink, you're probably sleeping under the bar. And that's kind of really overly dramatic, but it's a good example of disinhibition release, whereas there's this paradoxical excitation initially. And I don't know if it was this year or last year, but people wanted to see a story about disinhibition release, and I said, well, imagine grandma at your wedding or at your sister's graduation or something, and she doesn't really drink except socially, and so she has 1 glass of Pinot Grigio, and she's overly chatty and dancing with everybody, and by her 2nd glass of Pinot Grigio, she's basically laying on the floor somewhere, and you've got to pick her up and put her on a couch and get some water in her. So that's a good example of disinhibition release. And so as you go through these stages of anesthesia, stage 3 is where we see the patient lose consciousness. And so this is where, if any of you have ever had a procedure done, the anesthesiologist or the nurse anesthesiologist will say, okay, now start from 10 and count backwards. And this is when they're inducing this agent with an infusion. You'll say 10, 9, and then boom, the patient's out. Some patients may make it to 7, some patients barely make it to 9, but most people are in that ballpark. And so at this point, there's no pain reflexes at all, but the respiration is still occurring and it's regular, and blood pressure is maintained. Okay, and so whether or not you need to go to stage 4 of anesthesia, which results in medullary depression, would kind of depend on what type of procedure and how involved. So if you think of major thoracic or abdominal surgery, you might be thinking, yeah, we're probably going to need medullary depression. And so the patient now has really severe respiratory and cardiac depression that needs to be maintained on another set of drugs. and mechanical and pharmacological support. And so they'll be hooked up to a ventilator. Their rate and rhythm will be controlled with drugs. Whether it needs to go up or down would depend on the type of anesthesia that's being implemented or executed. Okay, so we've got 4 different stages of anesthesia. Different agents produce different outcomes in terms of which stage they bring a patient to. So obviously with stage 1, you could just think of like maybe a high dose opioid or maybe a benzodiazepine to have a reduction of pain and this notion of some amnesia. And then obviously when all the drugs that we're talking about are put on board, we're looking at pretty intense medullary suppression. So anesthesia achieves essentially minimal muscle tone, which is good because you can't have the muscles contracting, especially if you're going to be cutting through them. The patient's definitely unconscious. And then the respiratory and the cardiovascular activity might be blocked. And of course, the classic example would be, Snow White. Some high-yield terms that are associated or used with anesthesia would be this notion of balanced anesthesia. So this is basically a mixture of drugs that are both IV and inhaled. And so these are the 2 primary routes of administration for the majority of probably all these drugs in this lecture. So obviously if the patient's unconscious, you can't have them swallow a pill for obvious reasons. The other thing that's kind of unique to anesthetics, because many of them are inhaled, and they're inhaled through a mask or a respirator that has a ventilation type of equipment apparatus hooked up to it, is this notion of the MAC. And the MAC is kind of like a normalized value. We'll talk more about it in a few slides. But it's the classically defined as the alveolar contraction that's required to prevent a response of pain, of a pain stimulus, in half of the patient population. So the MAC is really a normalized value of the ED50. So the ED50 is kind of the classic pharmacological meter stick that says, what's the dose in milligrams where we see a response in half of the patients treated with this drug. We can't do a milligram concentration for a lot of these anesthetics because they're inhaled, okay? And they're actually supplied as liquids, okay? And they're put into this ventilating apparatus, and they're converted from their liquid state to their gas state, okay? And so you can measure the volume of the liquid, but the thing that determines how much of that liquid is going into the patient's lungs is calculated at a gas ratio. Okay, so it's so many units in a gas form. Analgesia, we know, is the reduction of pain or the management of pain. General anesthesia produces unconsciousness as well as amnesia, so the patients don't remember it. And there is dramatic skeletal muscle relaxation, and there's a loss of reflexes, of course. Monitored anesthesia is both supplied with oral and parenteral drugs with locals that can be delivered as a field block, and that's your classic example of lidocaine for dental procedures. Conscious sedation uses benzodiazepine-like drugs, generally with drugs for pain management. Okay, and so again, these are just kind of unique terms to the field of anesthesia. So the old anesthetics, ether, chloroform, cyclopropane, these worked very well, but they were also explosive. And so one of the risks to the surgeons and, of course, to the patient themselves was the fact that they could explode. And so back in the good old days when doctors used to smoke in front of their patients, that actually did happen in my lifetime. I remember going to the hospital and seeing my grandfather's cardiologist, of all people, smoking in the room with him. I mean, that seems like it was, millions of years ago, but that actually happened relatively recently. You can ask your parents about smoking on airplanes, smoking in restaurants, and smoking in the hospital. I think that's probably the most dramatic thing. But could you imagine one of these guys takes maybe not a cigarette, but maybe a pipe out and lights it up, and then this poor, especially if it's chloroform or an ether, gets into contact with that flame and boom. So the ether dome was invented to kind of minimize that, so that it contained the ether in a non-flammable type of enclosure. But there were still accidents because you had to get the ether into the dome. And if some guy walks in with a pipe, kaboom. So that was a problem. So the layout for anesthetics can really be summarized, divided by those that are inhaled versus those that are administered IV. And typically the IV ones are used for the induction phase of anesthesia, so to reduce anxiety and then to control pain and then to put patients to sleep. Okay? The inhaled anesthetics basically maintain anesthesia. So once these phases of anesthesia that we talked about, stage 1 through stage 4, have occurred, then these drugs are put on board to maintain that, to maintain those stages. And this also becomes kind of the outline for your drug list, which is expanded upon a little bit later. So let's look at some of the inhaled anesthetics. So these are gases, and the first one that's used historically and still used for good reason is nitrous oxide. So this is N2O, all right? Remember from organic chemistry, nitrous is N2O. This is not NO, which is nitric oxide, okay? This is a vaporized halogenated hydrocarbon, if you're an organic chemist. At room temperature, it's liquid, and it also contains a fluorine molecule. And a good example would be drugs like halothane. Okay, and then these were also derived from that, so the fluorines, so desflurane, N-fluorine, and so forth. Okay, so you've got your gases and your vaporized halogenated hydrocarbons, and these are the two groups that are, commonly used for inhaled anesthesia. Right. So, as we talked about earlier, the MAC or the MAC is kind of like this normalization constant that we can use to compare anesthetics. Okay, so really, which anesthetic is more potent? Well, we have to look at the MAC. Okay, so what is the MAC? It's, these are just some different ways of looking at this from different angles. So the MAC is inversely proportional to the potency of the analgesics, and that's depicted here. So drugs with really large MACs, okay, are not potent. Drugs with small MACs are very potent. Okay, so it's inversely proportional. All right. The volume of gas in the lung, and so this is how it's been numerically described. It's the volume of gas in the lung that's needed to prevent the response to a 1-inch scalpel cut in half the patients at sea level. Okay, so obviously altitude plays an important role. Okay, the MACs are additive. Okay, so if you've got two drugs on board, one with a 0.75 MAC and one with a 0.25 MAC, the total MAC, okay, is 1. All right, meaning the total ED50 in terms of that patient's response to this scalpel cut is going to be additive with both drugs on board. Okay, so the more drugs, theoretically, the more drugs that you put on board, the less the patient is going to feel that scalpel pain. Okay, and so a lot of this, as we go through all these drugs, one thing that you should remember is that we're not typically using these drugs alone. To induce anesthesia and get a patient prepped for surgery, it's not which one of these is better, it's when do you implement them, okay? Because the fact is that, a lot of these patients are going to use several of these drugs, or are going to be exposed to several of these drugs during the surgical procedure. All right, so that's one thing to kind of keep in the back of your mind. You can't really say which one of these are better because they're used for different things, okay? So in terms of the MAC, you can look this stuff up. Okay, every anesthetic has this defined MAC that's reported in textbooks and charts, and of course the anesthesiologist knows these MACs very well. And what's interesting is that as you start putting on other drugs, so adjuvant therapy actually lowers the MAC, okay, to make it more potent. All right, and that's one of the key benefits is that, if we know that this volume of anesthesia will produce this side effect, okay, we can lower the volume of anesthesia and we can put another drug on board, like a benzodiazepine, all right, and we can actually make this particular side effect shrink. We can make it less inclined to happen. And so what it does is it actually makes these drugs a little bit more safe. It actually widens their therapeutic index. Injected or some anesthesiologists will actually give like a benzodiazepine early on, so before the patient even goes under. It could be IV, it could be oral too, but yeah, most often IV. And those adjuvant drugs are the ones that are used to help induce anesthesia. And so then by having slight anesthetic induction already on board, we don't have to give as much of the maintainer anesthetics to produce the overall desired effect. Okay? So there are things that, there are physiologic factors and geographical factors that can change the MAC. The patient age, the time of day, interestingly, thyroid function and body temp are known things that can change or alter the MAC. Okay? Things that typically don't affect the MAC, ironically, is the sex of the patient, the duration of anesthesia, changes in body chemistry, oxygen tension, and anemia. Okay? So from an anesthetic standpoint, there are things that you need to kind of be aware of. And obviously we alluded to, changes in altitude as well. So one of the other things that these two researchers kind of came up with is that the potency of these anesthetics can be predicted based on the drug's lipid solubility. And so what they did is they looked at all these different drugs and they compared the MAC to the oil-gas partition coefficient. And it's kind of an approximate or surrogate reporter of lipid solubility. Okay? So anesthetics have a kind of a unique pharmacokinetic approach. Is because you're looking at the drug going from the alveolar lung compartment to the blood to the brain. Okay, so there's actually, three different partitions that you have to look for. And so this oil-gas partition coefficient kind of takes those into effect. And we're not going to do the kinetics to demonstrate that. And so, brain, you think oil, lipid soluble, and of course blood, you think water soluble, right? And so as the MAC increases, let's say it this way, as the MAC decreases, the oil-gas partition coefficient increases. Okay, so they're inversely related. All right. What does this mean clinically? Well, the more soluble inhaled anesthetics, the more water-soluble inhaled anesthetics have actually longer durations of action, which would be kind of counterintuitive based on what we know about volume distribution. Okay. And so just to kind of look at, two opposing, so here's nitrous oxide, which theoretically has the largest MAC, and here's methoxyfluorine, which theoretically has the smallest MAC on this chart. Let's look at it here. So here's the role of the blood-gas partition coefficient. So nitrous oxide has a really steep arterial tension curve, and so what does that translate to? It's got a really low blood-gas partition coefficient, as demonstrated by the Greek letter lambda. It's less soluble. Okay? It has a fast onset of activity, which is why it's most often used as an induction agent, and it's got a very large MAC. Oh, sorry. Methoxyfluorine, however, is kind of the opposite. It's got a less steep curve, which translates to a very high blood-to-gas partition coefficient. It's highly soluble. It's got a very slow onset of action, so you can't use it for induction, but you can use it for what? Maintenance, right? For maintenance anesthesia. And it's got a lower MAC. So that's why certain drugs are used for induction, okay, because they work quickly. And the reason they work quickly is backed up by both the blood-gas partition coefficient and the MAC. And then we've got other agents that work slowly, and so you can't use them for induction, but you can use them for maintenance once the patient's already sedated. Okay? And that's kind of the key concept here. There's another way of looking at this, and this is a bucket metaphor. This is the way it was kind of taught to me. So if you've got a big MAC, right, big MAC, you've got a small lambda, okay, and the bucket, okay, is actually much smaller. So the lower the blood solubility, the more readily it leaves the blood, enter the brain, and the induction process is faster. So the amount of time it takes to fill this bucket up is relatively small compared to this. Okay, so this is why we can use nitrous oxide to induce anesthesia, because the bucket fills up very quickly and goes to the brain. This is in contrast to, so I was thinking, it's like, okay, here's a Big Mac. What's a Little Mac? I was like, the children's menu? Well, Little Mac is, I guess, from the video gaming industry. I don't know. You guys play video games? I don't know what this is, but apparently he's a character on a video game. So a Little Mac is signified by a very large lambda, okay, compared to that one. And the bucket now is much bigger. Right? So it's going to take more time to fill this bucket. Right? And so the induction rate of anesthesia for halothane would be quite slow, which is why halothane is used as a maintenance anesthetic and not an induction anesthetic. Okay, so those are a couple ways of looking at it. The pharmacokinetics and the pharmacodynamics of anesthetics is a little bit different, which is why we spent a little bit of time on that. Okay. So uptake and distribution, what does it mean? So what are the factors that control uptake? So obviously the solubility of the drug, all right, and then cardiac output or perfusion. So how fast is that, because it's going, remember this is getting, it's IV injected, right? So we're looking at perfusion. How quickly or how fast or how efficient is that drug being pushed through the vascular circuitry? Okay, and then likewise, how efficient or how quickly are the lungs working? Okay, if there's lung failure or patients don't have good lung function, that's going to play into the distribution of this anesthetic. Okay, and so by way of distribution, we talk about tension. So tension really means concentration. It's the amount of drug per volume. And if we go back to our 3-compartment model, we're looking at the movement of this anesthetic that's usually inhaled through the alveolar compartment, to the blood compartment, and to the brain compartment. And so, each one of these has its own K value, and so the blood gas coefficient, the brain-blood coefficient are listed there. And then, of course, on elimination, how do you eliminate the drug? Well, some of these drugs are just breathed out. And that was one of the problems with some of the earlier drugs, is that after the patient's surgery or the procedure was done, they would breathe out the anesthesia. Okay, and again, if somebody come in with a pipe or something or an open match, they're literally breathing out volatile compounds that could ignite. So that's, again, while they're hooked up to the ventilator, the machine is also pulling obviously their CO2, but also some of the drug back out, right? And then, of course, some of these drugs do circulate through the blood compartments, and halothane is a good example. It actually has a liver metabolic component to it. Okay, so there can be some residual products coming from these drugs that may have physiologic activity systemically. Okay, so what is the perfect anesthetic? Probably Goodman and Gilman's pharmacology textbook. You read that and you will be out like a light. I know, because that happens to me all the time. But the perfect anesthetic would be a drug that produces rapid onset or rapid induction, okay, but would also be rapidly terminated. So when you remove the drug or when you stop administering it, the effects of it would go away very quickly. The perfect anesthetic would have CNS concentrations that would facilitate leaving the CNS to remove the effect. And so you don't want any residual drug lying around in the CNS compartment, because that's going to reduce CNS activity after the surgical procedure. We'd like to see no side effects after the procedure. And of course, we don't want it flammable and we don't want it explosive. From the patient's perspective, we'd like to have something that's quite pleasant to inhale, because there are some drugs that as you inhale them, they leave specific taste and aftertaste in your mouth and your lung compartment that could be irritating after surgery. And ideally, they would have minimal liver metabolism and a low blood gas solubility, owing to rapid onset. Okay, so that's the perfect anesthetic. None of these drugs are perfect, but some of them come pretty close to satisfying the majority of these criteria. So all the inhaled anesthetics are actually going to produce unconsciousness. They're going to produce amnesia. The patient won't remember what happened. Okay. They will all produce motor incoordination, so the patient won't, during surgery, the patient won't reach out and grab your hand. And their breathing should be depressed. Okay. Some of them produce negative cardiovascular effects, which could be dangerous. And so that's why, during these surgical procedures, the patient's heart is always monitored. Okay. And then there's always a group of drugs, both positive and negative chronoendromotropes, that are available if the patient goes one way or the other in terms of heart rate or blood pressure. Okay. So nitrous oxide is an NMDA receptor antagonist or blocker. Okay, and it's laughing gas. You've probably, I know you've seen it on TV and in movies dramatized. But it's relatively a weak anesthetic, but it's a great analgesic. Okay, which is why it's used most often in doctors or in a dentist's office. Okay, for minor dental procedures. Because it's less soluble, there's a very fast onset of activity. All right, and you can maintain vascular tone because actually nitrous oxide, and I don't know the mechanism, I don't remember it, but it actually stimulates the release of epinephrine. Okay, so you theoretically could imagine that if somebody takes, or if somebody is administered too much nitrous oxide, and there are treatment parameters or treatment guidelines as to how much is enough, you can see a burst of epinephrine which would definitely result in elevated blood pressure. It doesn't really depress the respiration rate or cardiovascular outcome, even in spite of this epinephrine, when used at the normal doses. The smallest effect is on the respiration of the inhaled drug. The main adverse effect, and this is for patients that routinely have exposure to nitrous oxide, is this diffusional hypoxia and megaloblastic anemia. Okay, but if you're just using it for, that one impacted wisdom tooth or, that one cavity that's hard to get, the side effects are relatively minor in a normal, healthy patient, and which is why this drug is so routinely used. The volatile anesthetics, again, we're going back to that GABA receptor. Mechanistically, they operate at various subunits within that GABA subtype A receptor. And there's a few reasons or a few hypotheses why we think this works. We think, the most often cited hypothesis is what's called this critical expansion hypothesis, which basically says that there's going to be a disruption of the membrane fluidity in specific domains of these neurons that contain these GABA subtype A receptors. Remember, there are GABA-specific neurons that release GABA, okay? But through the entire CNS, there are tons of GABA receptors on other neurons, right? Because that's the inhibitory neurotransmitter, right? So you can have a norepinephrine-secreting neuron that has the GABA receptor on it that would be inhibited or altered by one of these drugs. So just remember that in the back of your mind. And so, other hypotheses in terms of how these drugs work are listed here. But essentially what we think is happening is it's some type of modulation or alteration of the GABA receptor complex, which changes the physiology of those neurons. Okay? Halothane, let's go into the halothanes, affects multiple ion channels. All right? And so if you do that, you're going to reduce or depress nerve conduction, and the outcome is going to be less breathing, less cardiac contractility. The immobilizing effects have been linked to its effect on binding of potassium channels, specifically in cholinergic neurons, so acetylcholine secreting neurons. And then halothane's effect is also due to the binding of NMDA and calcium channels, which produce hyperpolarization. So lots of mechanisms that these drugs are hitting. And so that contributes to their use as anesthetics, producing all of these depressant type or inhibitory type physiologic outcomes. All right. So what is halothane? It's non-flammable, so that's good. It's halogenated. It's a hydrocarbon. And it can be used for the induction, but it's most often used for maintenance. Okay? When we talk about induction, it would be co-administered. It wouldn't be used as a single agent, but it would be co-administered with something else. Okay? It's got a pleasant induction process, and it doesn't really produce any excitement. So very little disinhibition release. Okay? It's the only drug here that actually has any type of liver or hepatic biotransformation. However, pain management with halothane alone does usually not happen, which is why nitrous oxide is given concomitantly. All right, so nitrous oxide is the more potent inducer, so you can give nitrous oxide, which doesn't last very long, with halothane. Halothane lasts a little bit a lot longer, and so you get really nice anesthesia. Okay? Halothane also alone doesn't produce sufficient muscle relaxation. So again, you're supplementing halothane with something like a neuromuscular junction blocking drug, which we talked about way back in MOD. And there will be physiologic changes that will accompany halothane administration. So there'll be a reduction in blood pressure, there'll be a reduction in pulse rate as well as respiration. And so that would need to be either pharmacologically or mechanically or both supplemented and worked on so that the patient doesn't have dramatic changes in blood pressure. All right. Other fluorines, enflurane, kind of has this risk of a rare cardiovascular reentry phenomenon because it's a negative dromotrope. Enflurane is also nephrotoxic, and it's also seizure promoting. Okay, so it's really hardly ever used. Isoflurane, however, it's about as efficacious as halothane. Okay, but it's pungent, and so patients don't really like it because it's kind of a respiratory irritant. Sevoflurane, a little bit better. Its induction time and recovery time are fast, and there's really no respiratory irritation, but you really wouldn't want to use it in patients that have underlying kidney disease. Okay, so there's lots of options out there. And of course, just like anything else, you look at the patient's profile and you see which drug would be the best fit for them. Okay. So what are some of the effects on some of these inhaled anesthetics? Well, from the CNS perspective, we'll see a reduction in metabolic activity of the brain. We'll see a reduction in vessel resistance, and all that will increase blood flow. So the side effect you'll see, especially with something like enflurane, would be muscle twitching or fasciculations. Okay. From the cardiovascular arena, we would see reduction in arterial blood pressure. We would see reduced blood flow to the liver, an inhibited or reduced cardiac output, and some peripheral vasodilation. And so enflurane and halothane are kind of notorious for the reduction in cardiac output. And then all of the fluorines listed here would produce peripheral vasodilation. And then respiratory, we see respiratory dependent reductions in tidal volume. Most of these drugs are bronchodilators from a mechanistic standpoint. The only exception would be desflurane, which is known to produce bronchospasm. Okay, and so especially if the patient is intubated or they have a history of COPD or asthma, you might want to maybe think twice about that. All right. So some notable side effects to the group of anesthetics that we could look at globally is this notion of malignant hyperthermia. And typically when you combine a lot of these anesthetics with neuromuscular junction blockers like succinylcholine, you can see this production of malignant hyperthermia. Mechanistically, we think it comes from a reduction in calcium uptake into the SR, and we think that it's run by the ryanodine channels. All right, so the patient is actually they'll be really rigid, and of course they'll be hyperthermic. If it goes on for a long time, you can see rhabdomyolysis, and that's really coming from kind of skeletal muscle breakdown from that sustained rigidity. So there's an antidote, of course. We can give dantrolene, which will block those ryanodine receptors. The other notable side effect is this production of halothane-induced hepatitis. And this is coming from a microsomal metabolic conversion of halothane to this particular chemical moiety, which is hepatotoxic. All right. You can also see an autoimmune type of induction through a specific CYP enzyme, which produces a delayed hypersensitivity reaction. So those are the two kind of big side effects to some of these anesthetics. Okay. So that was the inhaled drugs. Let's look at some of the IV drugs. Well, we mentioned barbiturates early on. You guys remember what thiopental was used for? Yeah, truth serum. So you can use it for, and they have used it for interrogations. It lowers the patient's or the interrogatee's threshold so that they physically cannot tell a lie. And so if you look at like brain physiology, it takes more brain power to tell a lie than it does to tell the truth. And so if you're suppressing brain power, essentially, patients will just basically spill the beans, so to speak. And it's, because it interferes with their higher level thought processes. You can combine, you can use drugs that have a barbiturate/benzodiazepine-like mechanism of action. And the two probably mostly encountered is etomidate and propofol. There is a drug that's actually clinically relevant that looks very similar to PCP, which is, the drug that you learned about yesterday in drugs of abuse. And there are drugs that have more benzodiazepine-like characteristics that are very useful for producing anesthesia, specifically the induction phase. So let's kind of look at some of these. So these are the IV anesthetic drugs that are out there. Thiopental is kind of barbiturate-like. Etomidate and propofol have kind of mixed mechanisms that are similar to either or both barbs and benzos. Ketamine we said was PCP-like, and midazolam is benzodiazepine-like. And so some of these have slow onsets, and some of these have fast onsets. And so, in terms of the induction phase, you may want to supply nitrous oxide in terms of the inhaled anesthesia, and you can also co-administer one of these faster-acting type of drugs via IV. And so, and that's the thing with anesthesia, is that you're using several of these drugs for different reasons. Basically, you don't want to have the same side effect profile, and you want to induce anesthesia fast, but you also want to have the patient recover well. Okay? And so when we had talked about induction and recovery time is after the surgery is complete, because remember, the main goal of anesthesia is to have the patient be unconscious for the whole surgery. I think everybody's nightmare would be to wake up during surgery. That would just be a horrible, horrible thing to go through, both as the patient and then as the surgical team. And you've probably seen this before where, maybe a friend or somebody and it's always been dramatized on TV as well, somebody will go in for emergency surgery, and you don't really know how the patient is going to handle these drugs because you maybe don't have their full chart in front of you. So there are some patients who require more drug on board to get them to a specific state of anesthesia. And there are other drugs, or other patients who don't require as much. The patients that don't require as much probably get the same dose, or the standard dose, as a quote-unquote normal patient. That just translates to a slower recovery time. And so, you've seen the doctor or the nurse come out and say, the patient's doing well, your loved one is doing well, and then the follow-up question on the family side is, can we see him or her? And their answer is no, they're in recovery. And so recovery could take 20 minutes, it could take 4 hours, it could take 3 days, depending on and there's always stories of patients that have a very, very slow recovery time. And it's due to metabolic differences. It could be due to genetic mutations in specific receptors that were targeted with some of these drugs. But that's kind of the clinically relevant outcome to recovery time, is that, we've got tons of experience with these drugs. We know that when you discontinue the drug at a specific time point, the patient's going to wake up or recover from the sedentary effects of these anesthetics within a specific time period, whether it's 1 hour, 2 hours, 6 hours. But as those specific patients are identified as outliers, we get a better understanding of who is going to handle some of this therapeutic alterations. So this is kind of a nice table that kind of puts into effect the drugs, their relative induction and recovery time, and the main notice unwanted side effects, and then some specific clinical notes. I kind of like this table just for comparison's sake of looking at all those drugs. Let's go through some of them. So the barbiturates, remember, they're going to potentiate the GABA activity at the GABA receptor. And we said thiopental was the one that we had talked about earlier. This is the one that we said was truth serum. It's got really quick entry into the brain, highly lipid soluble. And anesthesia can be accomplished at the proper dose in less than a minute. Okay, but the duration of action is very short. Okay, so you've got to keep that drug, on the IV for the duration of the procedure. And so the duration of action is very short, but however, the elimination is quite slow. So the patient's going to feel very groggy and hungover for a longer period of time. And all patients almost exclusively complain of this garlic taste in their mouth. And so that's how you know a lot of those detective shows. Anybody watch Blacklist? You guys watch Blacklist? I'm like obsessed with that show. I think there was one episode I think where they had truth serum involved. What's his name? Red. I think he injected somebody with thiopental to get some information from them. I think that was the show. I'd seen it somewhere. Another drug that's very useful is midazolam, and this is a drug that's kind of like a benzodiazepine, okay? But we don't give it to patients for what we give benzodiazepines for. We give it for specifically the induction phase of anesthesia, okay? It produces reliable hypnosis, right? It produces amnesia and reduces their anxiety. And you can give it to them the night before the surgery. You can give it to them intramuscularly in the morning of the surgery, or you can mix it in their IV. Okay, and so it's been used as an adjuvant with both the inhaled and the IV anesthetics. Okay, however, because it's benzodiazepine-like and you're administering it IV, you can expect post-operative respiratory depression. So you do have to keep an eye on their respiratory rate. Okay, typically we'll use it as a pre-op to sedate them. And we can use it for induction, for quick induction of outpatient surgical procedures. All right. And so, and again, if you want to reverse the effects of midazolam, because it is benzodiazepine-like, you can use flumazenil to accelerate the recovery. So that reminds us that, mechanistically, it has enough benzodiazepine-like activity at the benzodiazepine receptor that it can be reversed with flumazenil. And so as this respiratory depression side effect becomes problematic, you can just give flumazenil and it goes away. So this is a great drug for a variety of clinical uses. All right. The drugs that have kind of a mixed acting barbiturate / benzodiazepine-like mechanism include etomidate and propofol. Propofol is the most commonly used. Etomidate, it's kind of falling out of favor. I don't even think I have much information. Yeah, I have some minor information about it. Propofol produces CNS and cardiovascular depression, and it's also an antiemetic. So that's another kind of useful type of clinical outcome for that particular drug. Let's look at etomidate. It's an imidazole derivative, and it's very short-acting. Globally, it suppresses the production of steroids. Okay. However, it's really good for patients that have pre-existing heart disease because it has really little to absolutely no effect on the heart. Okay. This is in contrast to propofol, which potentiates the GABA receptor activity, and it slows that channel closing time. And it also acts as a sodium channel blocker. Okay. And of course, you probably all remember, or at least heard of propofol. That was the drug that's been implicated in Michael Jackson's death. And the reason that he was using it was to use it as a sleep aid, meaning that, he may have had drug problems. I'm not saying he did, I don't know. But if you're using an anesthetic to fall asleep, that means that you've probably had tried, benzos, barbiturates, opioids, and so forth. And, so it's really kind of sad. I mean, this particular drug should not be given in the outpatient setting. This should really be administered in the hospital, right? With, and then because of its mechanisms, the patient should receive both, CNS, respiratory, as well as cardiovascular monitoring. And I think that that's really the thing that contributed to his demise. This particular drug has a really rapid induction time, okay? And it's been indicated for balanced anesthesia as well as outpatient surgery, right? And so, propofol you can see being used clinically for colonoscopies and so forth, but you wouldn't be administering this, at home. We wouldn't let the patient administer this at home because it's given IV. You can see prolonged sedation in the critical care settings as well. All right. Ketamine, we talked about, or I didn't talk about, but Dr. Persons did. We talked about PCP. Ketamine is a derivative, a clinically useful derivative of PCP. It's a non-competitive blocker at that glutamate's NMDA receptor. And if you really want to get into the molecular biology at the sigma receptor subunit, this drug is capable of inducing anesthesia, and it's associated with this dissociated anesthesia. So the patient's kind of in a semi-aware trance, and they kind of know something's happening, but not really, much like the way they would feel under PCP therapy. The problem is that it kind of dramatically elevates the SANS activity on the heart, and so you can see dramatic cardiovascular side effects. So both PCP and ketamine produces this dissociative phenomena, which produces this out-of-body experience. And you've heard of patients maybe who had been administered ketamine for a surgical procedure, saying that they had, died and they had left their body and they were looking down at themselves. This would be one of those drugs that could induce that feeling. It has really good analgesic effects, and there's some kind of mindful, colorful, vivid dreams. And typically, it takes patients to a happy place. And so then they kind of dwell on some happy thoughts, and this is where they would maybe see their mother or their father if they had passed away a long time ago. And this drug is kind of notorious for producing these kind of out-of-body experiences, much like PCP. Excuse me. So just to kind of quickly summarize, we had talked about the gases and the volatile liquids, okay, that are produced or that are administered with inhalation. We talked about some of the IV anesthetics and where their uses are. Understand that adjuvant therapy could be our classic benzodiazepines, atropine-like drugs, analgesics for pain management, which is coming up in 10 minutes, muscle relaxants so that the muscle is essentially not tense and you can cut through it. And of course, a lot of these drugs have the side effect of producing nausea and vomiting, so you want to front load them. The patients undergoing surgery with antiemetics. Some of these drugs shut down the GI system, so afterwards you want to supply them with proemetics to get the digestive system turned on again. Okay, and of course, the other component to surgical preparation is having the patient fast for a period of time. Why do you think that's so? Because you're giving all these drugs that basically remove muscle tone. You don't want them crapping on the operating table, right? You don't want them peeing on the operating table. So if they're empty, then it's a lot cleaner in terms of the surgery. And so, by this way, we can administer kind of the proemetic drugs after the surgery is complete to kind of turn on their digestive system and get things moving forward. Opioids, of course, we'll be talking about in a few minutes. Morphine and fentanyl. Fentanyl typically given as a patch, but these drugs are going to basically help with the pain in the wound itself and make sure that patients don't feel pain, or at least reduce their pain dramatically after the surgery. Okay, so these are all of the adjuvant drugs, and so what I've done is I've listed the drug with kind of its clinical use in terms of why it's an adjuvant. So the benzos relieve anxiety, and so you can see sometimes the night before the surgery, the surgeon or the attending will give maybe lorazepam, a small tablet just before bed, just because maybe the patient's not going to sleep well that night because they know the next morning they're going to have a big surgery. Antihistamines, some people are allergic to drugs and you don't know if they're allergic because they've never had surgery. So sometimes you want to front load them with antihistamines just to prevent any allergic reaction from manifesting itself. Some of these drugs do, like the garlic one, some people don't like garlic. My aunt hates garlic, and so whenever we cook spaghetti, I can't put any garlic in it because it makes her throw up. And so you want to have antiemetics on board so that the patients are not nauseous or even worse, vomiting as the drugs for surgical induction or anesthesia induction are being front-loaded. Opioids, of course, if you're going to do surgery, that's going to hurt. So you're going to talk about pain management after the surgery is complete. Of course, as the surgery is happening, you may want to consider putting some opioids on board to prevent pain when the patient wakes up, kind of thinking ahead. Atropine is going to reduce secretions within the GI and the endocrine system. It will also prevent bradycardia. Some of these drugs are cardiac depressants as well, or cardiac stimulants.